needle at about a depth of 80 to 90%, and then inject air, and the air creates a plane of separation between the Gossamer's membrane or the Duas layer, and you get the big bubble. But sometimes you can get it in a single attempt, and sometimes you may require multiple attempts to achieve the same. And if your needle is placed too superficial, you get a lot of surgical emphysema. That means your entire cornea becomes white, and you're not able to, visualize what's happening at a deeper plane. Or if you go with your needle and you go too deep, your needle goes into the anterior chamber, and then when you inject the air, you find that you have a bubble that's in the anterior chamber. The success rate, even in experienced hands or with using a needle, is in the range of 65 to 70%. Simplifying the technique, what changes we have done is we first use a suction trephine, that's the Baron Hesburgh trephine from Catena, and using this trephine you can go down and make a cut of about 80 to 85% depth. So normally we do about 7 turns, each turn cutting about 60 microns, so 7 to 8 turns takes you about 420 to 480 microns at a trephine size of 8.5. And after you have done that, the next step that we do is we do a debulking. So we basically remove about 40% of the stromal tissue. By doing this, we ensure that the needle or the cannula can be placed much deeper. The amount of stromal tissue is debulked, so you have less chance of the stromal emphysema forming. And once the bubble is formed, when you deflate the bubble, you don't have to do this step of doing the anterior lamellar keratectomy. You can quickly deflate the bubble, and thereby you can minimize the amount of endothelial trauma because your Decimus is actually rubbing on the iris once the bubble is formed. Only thing is, if you have a very advanced keratoconus and your cornea is very thin at the apex, sometimes by doing this step you find that when you remove the anterior lamella, sometimes the apex of the cornea can have the Decimus nearly exposed, and then when you try to create the bubble, the air, instead of finding its way posterior, it starts coming out anteriorly. So on an OCD, if you see that the apical part of the cornea is less than 300 microns, then maybe you will not do an anterior lamellar keratectomy. So that's the air injection cannula, which is a bottom port cannula. That's the pointed dissector with which you make a small pocket into which you put the cannula. And that's a stromal fixation forceps that helps you stabilize the peripheral edge of the corneal tissue once you make the pocket. So if you see, we have already done the anterior lamellar keratectomy. You go to the periphery, you have a small ridge. You grasp it with the stromal fixation forceps, go with your pointed dissector to the base of the cut, and then make a small pocket only for about a millimeter and a half. Put in your blunt cannula into this pocket and just wiggle it, and you will find that if you're at a right deeper plane, the movement will be quite smooth, and without too much of effort, you will be able to introduce it centrally into the cornea. And now when you inject air, you will find that you can get the bubble, and in a much more controlled fashion. And because you have not done a paracentesis, the bubble cannot really expand very fast because the aqueous is kind of tamponading the bubble. So you can reasonably increase up to a diameter of about 8 millimeter, and beyond that, if you will again start feeling a lot of resistance. Just to show you the different, most of the time after a while you start getting it very consistently. And even with the femtosecond laser, you can do that. It's an expensive way of doing it, but if you have this tool, no harm, using it on your patient. So in a keratoconus patient with eczema, we have done a vertical cut and also a horizontal cut. The horizontal cut is about 300 microns, and then you can see that the anterior lamella can just be peeled off. The vertical cut goes to about 450, so you have a peripheral cut that's going for 150 microns deeper. So you go to the periphery and catch with your stromal fixation forceps, make that small pocket, introduce the cannula, and once it is in plane, the rest of the steps are quite similar. The two are separate surgeries, but if you look at it, they will look like as if they look quite symmetrical. And the formation of the bubble also happens in a quite predictable manner. If you get a bubble and you're not very sure whether you've got a bubble or not, you can do the small bubble test that's been described both by Fontana and by Donald Tan. You make a paracentesis, release the aqueous, put in a small air bubble, and then the bubble remains in the periphery. And so that's a sign that tells you that you have got the formation of the big bubble. And once the bubble is deflated, this small bubble which is in the periphery comes to the center. When you deflate the bubble, use a sharp 15-degree knife with the cutting edge facing forward, and you go in the mid-periphery towards the center part of the bubble where the separation is the maximum, and you come out quickly as you're coming out, you slice it so that you get a large opening. The other way of doing it is to put a viscoelastic on your surface, and now when you go in with your knife and you deflate the bubble, the viscoelastic tamponas the air that's leaking out, and you will find that the bubble collapses very slowly. And if you have done a paracentesis before you do this step, your decimates will come back very slowly. But if you haven't done a paracentesis and you try to deflate the bubble, you will get the decimate that kind of snaps back into position, and the risk of perforation can be much higher. So once you have done that, you can remove the residual stroma that's there. If your opening is very small, you can use a spatula or the trifacet spatula, go into the space and then slice it open using a sharp knife. And once you have done that, you can use a pair of scissors to split it into 4 segments. And some people at this point of time put in cohesive viscoelastic to push the decimates back and then remove the residual stroma. But once you put viscoelastic, you cannot really see the decimates membrane, and sometimes that can be counterproductive, because once your opening is enlarged, all the viscoelastic comes out, and if you cannot see your decimates, sometimes you may end up traumatizing it. So for that, if you want, you can put in some amount of trypan blue, which will stain the stromal side of the decimates membrane, and then you can put in viscoelastic so you have some visibility of the decimates at that point of time. It's important to keep the surface moist at this point of time. If the surface is very dry, the decimates kind of drags onto your instrument, and sometimes you can perforate as a result of that. So once you have removed this stroma, you see that the decimate has a little granular appearance. It's not a very shiny appearance, and that's what Dr. Dua has shown, that there is another layer that's present there, which is composed of about 10 to 12 microns in thickness, and it's a kind of a condensation of the posterior corneal stroma. The donor tissue punched out, for keratoconus cases, usually the same size. You peel off the decimates membrane. You can either directly peel off, or you can use a Merocel sponge to remove that. You can even stain it with trypan blue at this point of time. And this is placed back in position, and the suturing technique can depend on your preferred suturing technique, whatever you have been using in keratoplasty. But for beginners, it's better to put intraoperative sutures because you can manage astigmatism better. And in the event that, even if some sutures are not placed properly, you can always replace them intraoperatively. Although this is the kind of bubble that you see most of the time, if you try to enlarge your bubble too much, you can sometimes end up the bubble rupturing once, so that's why it's important that once the bubble reaches, up to 8.5, and you feel a lot of resistance developing at that point of time, usually we stop. And at this point of time, once you have removed the stroma, if there is a little bit of residual tissue in the periphery, we just trim it down rather than trying to go below it. That's to show the different kind of bubbles that form. You can have a bubble which has a very kind of glassy appearance instead of the dense white border. And sometimes you can get a mixture of both. You can get the type 2 bubble, or you can get a combination of both. What happens when you don't get a bubble? If you don't get a bubble, or if you have a scar that's touching the decimates membrane and you don't want to go ahead and inject the air bubble, you can do this manual technique where you have done a trephination up to 80 to 90% depth, and you can then go with a pair of blunt scissors and create a pocket 360 degree peripherally, excise it, and then use the Malbrand's peeling technique to kind of peel off the residual stroma. And you find that if you are reasonably deep enough, as you peel, the peeling process will be quite effortless, and you don't have to really do any sharp dissection at that point of time. Post-op medication, usually we use the full-strength steroids only for 4 weeks, and then the patients are kept on soft steroids like fluoromethanon or rocaprate, and they continue till the time the sutures are in place. And besides that, we put them on lubricants. The antibiotic drops are for a week. Again, in most of our indication, 85% of the cases that we have done DALK have been for keratoconus, and the success rate with the new instruments have been up to almost 92%. The outcome, the unaided vision has been about 618 and best corrected vision of 69, and the average astigmatism has been in the range of about 3.5 to 4 diopters, ranging from anywhere from 0.75 to 9 diopters. And usually the astigmatism is seen after a complete suture removal, because while suturing, you do ensure in the intraoperative keratometer that you get a nice round reflex, but when the healing is asymmetric or some sutures become loose much earlier and you remove them, by the time you do a complete suture removal, you realize that you end up with a lot of astigmatism. We've had microperforation in about 8% eyes, and out of that only 15 required repeat air bubble to settle the Descemet's membrane. We have done laser refractive surgery in some of the patient post-suture removal, and we have also done phakic implantation. And if you don't achieve a big bubble, you find an event from cernicola. I'm sorry, you're not able to read anything on that. And then in the two groups, they have found that the final visual acuity, the best spectacle visual acuity in both the groups is similar. Although the rate of recovery when you leave behind some amount of residual stromal tissue, it takes longer for the visual recovery as compared to cases where you have had an exposure of the Descemet's membrane. Newer suction trephines like the Moria suction trephine, which has, you can preset the depth, at 400 or 450 microns, and then when you do the suction trephine, it ensures that, even if you make extra turns, you will not enter into the anterior chamber. And the newer femtosecond laser and the intraoperative OCT, these are going to change the way you do the big bubble technique. So basically, in conclusion, DALF is a good option for patients with, ectatic corneal disorders or patients where the endothelium is healthy. And basically, for your initial cases, you should avoid any case where there is a scarring involving the Descemet membrane. The cornea is very steep and should not try to make the bubble become very large to go beyond the edge of the trefination mark. And use of modified instrumentation does make the learning curve smoother. Thank you. So next we can go on to